Okay, so Assalamu alaikum. I would say good morning, good afternoon, good evening, depending on where you are. So we welcome you all on behalf of Academic Neonatology Group and APPNA Pediatrics to this wonderful, wonderful monthly meeting which we have been doing. We had a gap because of Ramadan Kareem, and we are resuming our monthly meeting again. And today's meeting format is a journal club, and I'm very excited about it. And you already might have received the article. If not, you're gonna know in next probably 30 minutes everything about it. And this will be like a quick review of the format. So we will have introduction of the speaker. We will have like 25 to 30-minute talk, and then we will have question and answer session in the end. Our only request is that please mute yourself if you're not speaking. And then if you want to speak, you can always unmute and you can freely ask any questions. You can also ask questions in the chat, and we will review those questions in the end. There's something I always believe in called subconscious learning. Like the subconscious learning is you learn something and you really don't realize that you learned it. And this is one of those activities. Like the more we involve, the more critical thinking we will develop. And that's the purpose of General Club we usually have. And before wasting any more time, I am going to give this virtual podium to Dr. Nasser Rashid to provide you the introduction of the speaker, and then we will go ahead. Over to you, Nasser.
Assalamu alaikum, everyone. And again, same way, good morning, good evening, good night. I don't know where we are in like 3, 4 different time zones. But first of all, thank you, Safdar, for a brief introduction. And I think this is one of the activity that we had been planning for quite some time. Obviously, doing general clubs is a wonderful way of learning for all of us, including myself and all of us that have been practicing neonatology. We learned every time we have a new article being published, and we review it and we learn from each other. So a brief introduction of Dr. Hafiz Zeekash Malik, that what I have received from him is that he's a graduate of Government College Lahore and completed his MBBS from King Edward Medical University. And then he did his 4 years of MD pediatric training at Mayo Hospital, which is still affiliated with King Edward Medical University. And then he did 2 years of MD neonatology with Children's Hospital Lahore. So he has a tremendous experience of working in 2 very busy units, both Mayo Hospital in Lahore and Children's Hospital. And I think right now he's currently pursuing fellowship in Royal College of Physician and Surgeon. I'm going to give you the name of the place where he is pursuing, which is St. Guy's Thomas Evelina London Hospital. I think he's going to be there for a year. That is my understanding. On his WhatsApp, there is a mention about PhD. So I don't know if I skip it, he can give us a brief introduction about what his PhD thesis is. So over to you, Dr. Zeekash Malik. Thank you. Shukriya.
Thank you very much. I am Dr. Zeekash. As Dr. Nasser is visible. Can I start now?
Yes, go ahead. Go ahead.
Okay, then I can start with the name of Allah. Bismillahir Rahmanir Rahim. Yes, today the topic of my journal club is the effect of oropharyngeal administration of the colostrum on the incidence of NEC, necrotizing enterocolitis, late onset sepsis, LOS, and death in preterm infants, a meta-analysis of RCTs to 2020. Okay, now initially I go for the background. In the background, yes, we have the following topics we include in our journal club. That is, first is the NEC, which is a necrotizing enterocolitis, which we all know it is the disease of the neonates, especially the preterms, and the LOS, late onset sepsis, especially the more worse in the preterm, especially, and both are the major causes of morbidity and mortality. My second important point here is the colostrum, which is rich in immune factors. And the third is oropharyngeal administration, OAC, of colostrum. Here it is the main in this general in this topic. Here our main is the role of colostrum in the preterm. So it boosts the mucosal immunity, of both mouth and the gut. So these are the background. Now, yes, I have following the inclusion criteria. Yes, the eligible studies had to meet the following criteria. The study type is RCT, randomized control trial. The participants are preterm infants, so we only include here are in this research the original article we have taken, which is the meta-analysis. Here the only the preterm infants are included whose gestational age was less than 34 weeks or with a birth weight of less than 1500 grams. The RCTs which were included in this meta-analysis focused on the comparison of the OAC, that is oropharyngeal administration of the colostrum, as monotherapy with saline or normal saline. So we compare the OAC with either the saline or the normal saline or normal water, or no intervention for the observation of the NEC rate. Yeah. And any question up till now? Somebody is asking, I think.
Yeah.
So we have studied the inclusion criteria. The study type is RCT, randomized control trial. We have discussed about the age and the weight of the preterm infant. And what we do here about giving the colostrum and the comparing with the simple saline or water or no intervention for the observation of the NEC rate. And the primary outcome we have included here, including the NEC stage 2 and more. So we include here what are the primary outcome here, and the others are reported. Articles we include here only are written in the English. And what are the exclusion criteria in this article, in this research? The exclusion criteria were as follows: non-human studies, reviews, abstracts, letters, commentaries, editorials, and case reports. So we not include any of these. We only include the RCTs, the randomized control trial. Any gray literature and conference abstract are not considered here. So in the methods, since all the data used in this review were acquired from previously published articles, so we only take just like we have studied that later on. Total 114 articles, 114 articles were included in the start, which was gathered after the PubMed and the Cochrane review. From the keywords we have write down and then we studied it. So because we have already taken from the previous research, so no ethical approval required. These articles searched systematically, like I have mentioned, just in PubMed M-Base Central up to May 31, 2019. So up to 2019. So
Dr.
yeah,
Zeekash, sorry to interrupt you. Can you do me a favor? If you go on the APPNA Pediatrics, where, if you go on and just make me host back so I can mute people who are,
sure.
you can make me host again.
Okay.
If you click on the three dots,
Okay.
there should be option. If you go on my screen, like, where I am, and it should be there.
Okay.
Yeah, if you make me host, then I can meanwhile take care of the background noise.
Yeah, I have not seen here.
If not, then we can just continue, and then we will request everybody to please mute yourself if you're not speaking. Thank you so much.
Thank you.
You can continue with your talk. Sorry about that.
Thank you very much. Okay. Now, about we have studying about the, sorry. Yes, we have in the methods. I have just said that because already we taken articles which are already published, so no ethical approval required. These articles are searched systematically in PubMed Central up to May 31, 2019. Search strategy, as I already told, used a combination of the mesh terms and the keywords following the PICO principle. So we use the mesh terms and keywords, and so by this way we search, like the keywords we use here are the colostrum, oropharyngeal administration of the colostrum, NEC, LOS. So we use these terms. So title and abstract of the initial board search results was screened to identify eligible studies by two independent reviewers. So they made the two reviewers, two men, which then reviewed all the articles and abstract which come up after the search. So by this way, some studies were included. In the start, there was a large study, like I have mentioned in the later figure. 114 studies were included. Later on, these two independent reviews were plus and minus all the studies. So at the end, we have only come up with the 9 studies. After that, full text articles were downloaded, read and assessed. Data extraction and bias control. Before going to this slide, I will show this diagram. Like in this figure, they have taken in the start, as you have noticed, records identified through database searching. Initially, 114 articles were included, and additional records identified through other sources, like from other PubMed, not in the PubMed or other. So other sources, 2 articles, and 114 in the major. So after this analysis, the 2 independent reviewers go through all these articles, and after the removal of the duplication, records after duplicate removed, so it come up to be 58 in number, and afterwards 38 were excluded more. So we that then the final the number come up to the 20. Then in 20 further reviews, further these 2 reviewers further excluded studies, like studies with no full text. 4 were excluded, and 5 more excluded because these are non-RCTs, and 2 excluded further because there were no other reasons. So after these deduction, studies included in qualitative analysis come up to be 9 in number. So studies included in quantitative analysis, that is the meta-analysis which we have now doing, they include only the 9 in number total RCTs. So data extraction and the bias control, data were extracted by using a predefined data collection form. So they made a data collection form, and here the question was there, like, to what are the major basic characteristics, what are the age, weight, gestational age, sample size, along with this also from primary secondary outcomes. So from these 9 RCTs, this question was there to collect the data. This data was validated with Cochrane risk of bias assessment tool. Okay, this is one of the tool which I have mentioned in the bracket, this ROB2. This is risk of bias 2. 2 is the number which was modified later on. Initially, it was simple risk of bias assessment tool 1. So this was a modified form, and it has 5 domains. So in this way, any data which was RCT, randomized control trial, we removed the biasness by 5 domains, and I have mentioned it by searching in the research. It has selection, performance, that is initially we select, then performance, we see the performance, then attrition, we remove, exclude some research, then report, and then other. So it has 5 domains, but in this way they performed ROB2 in this study, so to remove the biasness. Bias is assessed as a judgment, high, low, or unclear. So at the end of this ROB2, their judgment is either it is high, biasness is high in the study, is low, or unclear. So statistical analysis. Review manager. Version 5.3 non-Dick Cochrane was used to perform statistical analysis. So here following terms used in the statistical analysis, like R, relative ratio for dichotomous outcome, that is like those outcomes which have either yes or no, or which have only 2 answers. So relative ratio was used for them, while mean difference were used for continuous outcomes, and for both outcomes, confidence interval 5% was considered. Okay. So what are the objectives they have taken in this meta-analysis? Assess if OAC, previously just I have just talked about, it was now from onward this there was some good reviews and good things to read and study about. So what are the objectives they have taken? Assess if OAC reduce NEC, necrotizing enterocolitis, LOS, late-onset sepsis, mortality, nutritional outcomes, that is weight at discharge, day feedings, initiation, at what time the feeding was initiated, etc. And the final was the hospital stay. So these are the 5 main points. Initial 3 points are the primary outcomes. So in this meta-analysis, they have studied about the primary 3 outcomes, like that are NEC, LOS, and mortality. These are primary outcomes, and the later 2, that is the nutritional outcomes and the hospital stay, these are the secondary outcomes. So these are the main objectives in this study. And what are the results they have gathered in this in this meta-analysis? So total 9 RCTs were included, as I have already mentioned in the diagram below before, and the total number of the preterm neonates were 689, and the OAC, that is oropharyngeal administration of the colostrum, what we give here is the 0.2 ml, 0.2 ml every 2 to 6 hours for 2 to 7 days. So in these studies which they have gathered 9 RCTs, so they have noticed what are the way to give the OAC, that is the colostrum? It is only 0.2 ml and 2 to 6 hours the gap, and for 2 to 7 days. So there not more than 7 days was given to any child. Secondly, normal slice trial water or regular feeding were used as a control, as I already mentioned before. As a control, we use this. Outcomes, as I already mentioned, there are total 5 outcomes, 3 in the primary and the 2 in the secondary outcomes. That is NEC, LOS, and mortality are the primary. Feeding milestones and hospital stay are the secondary outcomes. So these are our results of the study selection. And the effects on incidence of NEC. NEC, so what we include results gathered from these meta-analysis. NEC rate was 4.7% in the study group. So in the study group, NEC rate find out to be 4.7% as compared to 7.7% in the control group. So we have noticed in this, specifically in the NEC, when we're talking about the necrotizing enterocolitis, before OAC, the rate was 4.7%, and when OAC was given, it was 7.7% in the control. So in the control group, it was higher, and in OAC administered group, lower. Developing in the OAC group was 41% lower than in control group, although the subgroup analysis no significant difference. So this is the important point which I will tell in more detail in the last. So although there was a difference, but difference was not statistical significance. And the second outcome, which is the LOS, we have studied that in the study group, that is where the colostrum was given, the sepsis rate was 17.8%, and where the colostrum was not given, sepsis rate was 24.1%. So there was a difference, but again, there was 22% lower in OAC group, but again, there was no statistical less than 0.08.
Hold on. Zeekash, hold on. Dr. Murtaza, please mute your phone.
Dr. Zeekash, you can also mute that person. Yeah, he muted now. Yeah, but I think the one of the mistake I did was I made you host and now I lost all the control. And if I can get that back, I can take over that. But we request everyone to please kindly mute yourself. Please continue.
Okay, I have made you host. Can you see now? I think I have made. Can you see? Yes. Okay, so we have studied about the results. In the primary outcome, we have studied the NEC, we have studied the LOS. Again, in the LOS, although there was 22% lower in the colostrum group, but the statistical difference was not significant. And the third outcome, which is the mortality rate, here again, in mortality rate, the one thing in the meta-analysis, 3 studies are excluded here with a total sample of only 505 preterm infants. So in previously, we have a sample size of 689. So with exclusion of the 3 studies, these three studies were excluded because in these 3 studies, the mortality rate was not mentioned here. So that's why these studies were excluded. So now mortality rate, the RCTs were total of in the six in number. Initially, there was 9 in total. So mortality rate, the outcome of the mortality rate was mentioned in only the 6 articles. So mortality rate was again higher in the control group, which is 13.5%, but in the OSC group, it was 8.6%. The risk of death in the OSC group was 37% lower than in control group, although there was a difference, but this difference was not statistically significant. Now the secondary outcome, which is the time to full feeds, it was reported in the form of the median and interquartile range. There was there was a statistical significance between OSA group and the control group. So p-value here is 0.02. So although it is a secondary outcome, but here statistical significance was present. Although in the previous 3 primary outcomes, there was no statistical significance was there. And the second outcome, which is the duration of the hospital stay, and again here in this secondary outcome, there was a statistical significance was there between these 2 groups, which is p-value is 0.01. So to sum up all these results, although it was a bit boring, to sum up all these results, the p-values we have seen, the p-value of the initial 3 points, that is NEC, LOS, and mortality, they are more than 0.05, 0.05. That's why these are not statistically significant. And in the lower 2 points, that is time to full feeds and the hospital stay, there these 2 points show the statistical significance as the p-value is less than 0.05. Okay, critical appraisals. Here the strengths, what are the strengths, that is these are the, they already included here all the RCTs. There's only the randomized controlled trial, and there are some limitations, that is very small sample size, because although we have taken 9 RCTs, but the sample size was 689, and there was a varying protocols, as some, like in three studies there was no mortality rate, and the rest of the studies have taken the other outcomes. So there's some varying protocol, and there's also risk of bias, although the risk of bias was declined with the ROB2 cost trial, but again there was a risk of biasness. And some discussion now. Although modern medicine may advance, but NEC and LOS are still devastating. As we all know, as a neonatologist, that NEC and LOS are very, very dangerous in our nurseries, as they have a high mortality and morbidity. NEC mechanism, like one of the patient I have just seen in the hospital here in London, with NEC, only the 6 centimeter gut was remained, and all the gut was removed with the NEC. So now, what you think? You can think what's the morbidity and mortality with this 6 centimeter gut in this neonate. So NEC mechanism is still unclear, and multiple preventive strategies, for example, amino acids, probiotics, antibiotics, have already been tested. Like here in ClinB guidelines in this our St. Guy's and Thomas Hospital, they have used Labina drops, which are the probiotics. Here, 4 strains of the bacteria used to prevent the NEC. Again, the NEC was not being prevented totally, and I have already mentioned that in our nurseries, 2 to 3 patients are there where the NECs was operated. So we can imagine what's the high risk for these NSCs. Antibiotics have already been tested. One retrospective cohort study has shown statistical significant NSC and LOS improvement with OAC. This is another study of these RCTs, which is also mentioned in the discussion in the final point of this research, that one cohort study has shown significant improvement in NHLS and building up immunity and oral priming of the preterms with colostrum to help improve from oral cavity being colonized by pathogens, especially in admitted NICU patients. So we also use this oral administration of the colostrum by the ear sticks, which we use. By this ear sticks, the colostrum is applied to the preterm neonates in our nurseries in London. So this is also important, that by this way the oral cavity is safe from the pathogens. That's why it can improve the further being of these terms, neonates. Now, what's the clinical bottom line? OAC is safe and simple, may improve feeding and discharge times. So as we have already mentioned, that these two are verily the major statistically significant, that it improves feeding and discharge times. And although no definitive mortality benefits, yet it is recommended as a routine NICU care, as you already know all. Now results. Now we have studied why this difference was not statistically significant. Although I have made a slide, but I can say that initially, the first point, as I mentioned here, OAC have no standardized operation set, and initial time of OAC varies in intervention duration. As we already know that in immunity is a long term, not short term. As in all these RCTs, colostrum was given in 2 to 7 days. So why not given more than 7 days? So that's the point where the immunity will boost up, because immunity is a long process, not the short process that you give the colostrum in the first 7 days and the baby has grown up immunity and fight from all the pathogens. So that's why the one of the reason that the statistical significance was not there in these RCTs, because we have inclusion criteria, we already give colostrum for 2 to 7 days. So if we increase the days of the colostrum, that if somebody do the research and increase the colostrum to more than 14 days, then definitely this difference was significant. Second point, colostrum was packed in plastic bags, stored in refrigerator and thawed at room temperature. This may inactivate some immune factors, so maybe this was the reason. Now, the third point, okay, this is third point I've mistakenly mentioned in fourth point. Contamination, maybe some contamination may occur as some studies show pathogen organism in mother milk samples. Although I have not mentioned it, but here in our cities, which we gathered, some milk samples which was in the refrigerator, and here they show some pathogens in the milk sample. So maybe it was the reason that the results were not statistically significant. NEC are not single factor disease, but as we already know, it is a multifactorial. That what are the, like if we study in Pakistan in children hospital, here the infection rate is very, very high. So we can say that like in some centers, the infection rate is more. So it is a multifactorial disease. What are the infection protocols in that unit? The nurses and the staff and the doctors are using the hand hygiene technique, our procedures are doing with a proper hygiene. So this is multifactorial. Small sample size. So a 5-year multi-center double-blinded trial has designed. It is mentioned in the research that this design is still ongoing. That is 5-year multi-center trial. Further directions. So what we can take up from these cities and from this general club now onwards, we have to take the larger RCTs, standardize protocols, and explore biochemical markers like CRP and others, something else. Assess long-term outcomes. What are the long-term outcomes of this colostrum? Now, conclusion. I conclude my journal club by this slide. There is evidence that OAC could not significantly reduce the incidence of NEC, LOS, and death, but there is a trend of positive effects. The OAC might reduce the time to achieve full enteral feeding and reduce hospital stay. So, although these two secondary outcomes are very, very obvious, that OAC is very important in time to full feed and the reduced hospital stay. And further studies with large sample size and a high quality are needed to confirm the effects of the OAC. From now, OAC is still recommendable as a routine nursing care for preterm infants administered into the NICU. And some discussion points: should we implement OAC universally? Yes, we can, because it is rich of immunoglobulins, rich of antibodies. How to optimize protocols? By proper refrigerating, proper, like in Pakistan setup, we can, although there was not now, we can start proper milk bank, where by including the, by seeing the Islamic Sharia, we can nominate the name of the patient. So if there's any link when the child is grown up, he can know that he is lactating mother or something else, and barrier in different settings. Okay, thank you very much. This is all my presentation. Any question I can.
First of all, Dr. Zeekash, thank you very much for volunteering to do this journal club. You're probably the first one that volunteered. So obviously, this was a big step in the right direction. And I really appreciate that what you have done and read the article and try to summarize things for us.
The comment I have is, and this comment is mainly for the trainees, residents, and fellows. Like whenever we do like a critical analysis of an article, especially meta-analysis, and one of the abbreviation which are mnemonic, which we use is called Spirit QR. And many of you might have been familiar with this. The S stands for like search strategy. In this case, for example, like what was the search strategy used for searching the articles on the online databases like PubMed, Embase, or wherever we are searching for. So that's called search strategy. That's the S stands for. And then P stands for PICO, which Dr. Malik actually mentioned about it, which is like what kind of population we are addressing. In this case, for example, preterm infants. And like intervention, what kind of intervention? In this case, the intervention is oropharyngeal colostrum. And then C stands for comparator, like was there a control group? And we have a control group here. And then what was the outcome which we were looking for? And that's the part of the spirit mnemonic, and that P is then inclusion criteria. And then was there a risk of bias? And then their I square, which stands for heterogeneity, like, you want to aim for as less heterogeneity as possible. Like if you have more than 75% heterogeneity, I mean, I don't want to use this term, but that kind of a garbage kind of study. And you want to have as low heterogeneity as possible. And then you have like the type of model. Was it a fixed model? Was it a variable model? And then Q stands for quality assessment. There are tools which can be used to assess the quality of the studies. And then how we interpret the results. Was there statistical and significance? And the statistical significance does not mean that you have clinical significance. I always give this example of blood pressure. Maybe you will not like it or not. Let's say if someone decreases blood pressure from 160 to 155 with the medication, you may have a statistical significance that you have that drop from 160 to 155, but that may not be clinically relevant because it may still not affect the risks involved with the high blood pressure. So that's how I give that example. And then there's a grade, the other term which we use is a grade, GRADE, which is basically stands for grade of recommendation, assessment, development, evaluation. And what is the certainty level of this study? Is it the high certainty, moderate certainty, low certainty? Technology, and I'm just talking about for fellows and residents. And there are very learned people on this forum, and I am not addressing them because they all know all of this. And so those are my comments. And then there are recently more studies I have looked up, recently published. There are more meta-analyses on it. They actually are more promising to even show it decreases the NEC and even late onset sepsis. They are from 23, and this study was published in 2020. And I am done with my part of the comments, and I see Dr. Junaid is here and Dr. Sajjad Rahman is here. Whoever is gonna go first can go first. Please unmute. You can ask any questions. Thank you, Dr. Junaid and Dr. Sajjad.
Go ahead, Sajjad bhai. Older people first.
Everybody. And let me first say thank you to Dr. Zeekash and Dr. Nasser Rashid for preparation and presentation of this meta-analysis. It was a wonderful job done by you.
Dr. Sajjad, we cannot hear you properly.
Is it okay now? Is it okay?
Yes,
mic is up. Mic is up. You need to pull back the mic.
Perfect.
Thank you very much. Many things to learn. Thank you very much. Let me first say a lot of thanks to Dr. Zeekash, Dr. Nasser Rashid for the hard work they have done in preparing this presentation. And I think you have laid an example, and in the next journal clubs, inshallah, we will continue with it. And I like more younger fellows to come forward and take this challenge. A lot of seniors are here to help them, and they can learn out of it. And thank you, Dr. Safdar, for organizing all this meeting. You have done a brilliant job for us. We are so confident now that every meeting will go very well. The second thing is Dr. Khushdil has sent me a message. He wants to comment on this topic. Probably he has got a good experience. So if you get Dr. Nasser Rashid, give him an opportunity, Dr. Khushdil. The third thing is it will be very nice if you can project forest plot in a meta-analysis and let the juniors learn how to read a forest plot. And you have been mentioning about heterogeneity, and it's all given on the forest plot. And what test is done, and what does this number mean, and how do you take it as a indication whether the results are good or not? Thank you very much.
So a couple of things. Arshad can go ahead and ask the question, but I have the forest plot on this study. If Safdar will let me the host, then I can show it to everybody. But go ahead, Arshad, go ahead and ask your question.
Sorry, that's my question, because Zeekash didn't mention about the forest plot. So Nasser, you will mention, huh?
Yep, I'm going to put it up, and then we all will look into it together.
Okay, very good. So that's the forest plots, meta-analysis shows a very different result than this study. If it is the same article, Dr. Sajjad, which I sent it to you?
Yes, I think so.
Okay.
Zeekash can tell us. Yes.
Yeah, okay. No problem. Then I will wait for Nasser, okay?
Do you guys see that?
Yes, Nasser, we can see it.
Okay. So, yeah, go ahead. Zeekash, you want to comment on it, or you want us to comment on it?
No, you can continue.
So I'm not a very, first of all, there are certain things. Hold on for a second. Let me go back in time. Let me look at the 9 studies that were included in this article, in this meta-analysis. And if you look at this table, They talked about what interventions were done, how long they were done, how frequently they were done. I think the largest sample size was from a study that was published from Egypt, and then followed by the study that had a bigger number was by Sherm, and then obviously Zhang. I think Zhang is also the author of this current review, and so he included his study also. So that's the first part. But let me go into the next part, and then obviously this is I cannot condense the full table in one slide. I read the article last night very briefly. I'm hoping everybody else read it. But if you look at it, they talked about the length of stay in the secondary outcomes and time to reach the full feed in different studies. And here, this is where I just want to point out of one thing, that about probably a year ago, if Junaid will remember, and I think Dr. Sajjad will remember, there was a discussion about the human milk bank in Pakistan and how we can do it in a best possible way in terms of finding the right way of doing it without not following the Sharia and the Quranic teachings. So that is something I think that this study has shown us, is that there's definitely, obviously, no statistical difference, but definitely some decrease in the length of stay that I will probably pull up in the next slides that we have to start looking into. So that is something that I think we need to take away from this article. The other one is that the risk of bias. And I was surprised when I was reading this study, is that, look at it, there is always a bias in any study that was done. And all of this were quote unquote randomized trials. But if you look at there was a selection bias both on the user ends and the intervention people who were doing the interventions. And there was no blinding of the participants and the personnel. There was no blinding of the outcome in several of the studies. And there was definitely some kind of a reporting bias and the attrition bias. So I honestly do not know how to design a randomized trial when you're doing an intervention like colostrum and a saline, and how you will blind it. The only way I can think of is to double blind, is to put some kind of protective kind of blinding tape over the syringe, whereby the person who is giving it does not know what he or she is giving to the baby. But at the same end, when you're dropping it in the oral buccal mucosa, the color will be evident. So what do you guys think about the blinding part of it? Anybody want to comment on that?
Yes, I can comment on it. Nasir, thank you. This is a very important point, and I've done meta-analysis with Zulfi Putta for a long time, and this is what I do most of my academic career. Blinding, methodologically, when you talk about it, it is big of a concern when your outcomes are more qualitative in nature. Like if you're looking at the pain outcomes, or if you're looking at, say, any of the psychological outcomes, if the participants are not blinded or the outcome assessors are not blinded, those outcomes might be affected significantly. Objective outcomes like...
Can you introduce yourself? I think I know you, but the rest of the people...
Yes. So my name is Amir. I'm a pediatric gastroenterologist at University of Iowa. I'm a tenure track faculty here and do meta-analysis. I mean, I published many of these, but this is a very interesting topic. So I don't think that the blinding of the participants would have affected the outcomes a whole lot, because necrotizing enterocolitis is a very objective outcome. Like even if even if the babies know, if even the mothers know, even if the nurses know, the necrotizing enterocolitis will happen, if that makes sense. Similarly, mortality is a very objective outcome. So the lack of blinding is a bigger concern than the outcome is qualitative in nature. The question that I had for you guys by the way, if I am the one looking at the meta-analysis, I think the biggest limitation is that even after putting the studies, the numbers are very small. And you mentioned the grade analysis, which they did not apply here. If you just look at, and if you allow me, I can just define the anatomy of the Forest Plus for the trainees on board. Nasser, if you keep the Forest Plus on the screen, I can just go through for the trainee. Just bring it up the A1. So on the left side, you have the number of, on the leftmost column, the name of the study, and then the number of participants next, and the total after that. And then each row has a summary estimate from each of the study. And then if you look at the second last column, it says the weight. So that's how much each study contributes to the meta-analysis, which is directly proportional or inversely proportional to the sample size. So if you have large sample size, the contribution to the meta-analysis would be higher. And same goes the other way around. And then the same data is presented graphically on the right. So not only the square is the size of the effect size, like in this case, relative risk. And then the line around it is the confidence interval. So just by looking at it, you can say, hey, the studies are small and the confidence intervals are really wide, which means that the studies are really small and the variance is a lot around the summary estimate. So if you pool all of the studies, it led to 0.59 or 0, which is the relative risk, the pooled relative risk with a confidence interval of 0.33 and 1.06. So if you define the statistical significance of it, and if you're looking at a dichotomous outcome, say yes or no, then if the confidence interval includes 1, that means that the results are not statistically significant. Now, a lack of statistical significance, as Safdar mentioned, does not mean that there is no clinical significance. So if you look at the relative risk reduction, which is 1 minus relative risk, that means that if you give the oropharyngeal stimulation with colostrum, there will be a relative risk reduction of about 41% in the intervention group compared to control. So I'm calculating that based on the summary estimate from the first forest plot. The I-square here is 0%, which is excellent. I think most of the studies are showing a similar effect, which is sort of encouraging in that sense. And then the rest of the forest plot, including for the sepsis, also had a very similar sort of impression.
So since you're on the topic, can you elaborate a little bit more on the I-square? Because you talked about it, low, moderate, like substantiative, and then considerable. Can you elaborate a little further? Thank you.
Yes. So I-square is, so whenever you pool the studies together, some of the heterogeneity is expected. Like if we replicate our study on the same topic with the same intervention and same control group, same population, your summary estimate is not going to be the same. So there is some expected heterogeneity from one study to the next study. What I-square tells you is that how much of the heterogeneity or variability, and we're talking about statistical variability here, how much of the variability from study to one study to the next study is unexpected, if that makes sense. So an I-square of 0% means that there is actually hardly any variability out of what you would have expected anyway. But if, say, the heterogeneity is 25% or 50% or 75%, that would tell you that this much of the heterogeneity is unexplained. And then you basically further look into subgroup analysis or a sensitivity analysis to explore that. Okay.
Coming back to the first one, when they're talking about the oropharyngeal colostrum, and chi-square is 5.8. Would you elaborate it for the rest of the group?
For the I-square here, or so
the chi-square.
Yeah, so chi-square here is 5.8. So that's basically tell you, so this is a simple chi-square of looking at the value of the chi-square statistical set test itself, which is based on the degree of freedom of 7, which is n minus 1. So the total number of studies minus 1. And you get a p-value of that, which is 0.56 out of that. The I-square, again, is a sort of a summary of what I explained earlier, that it is sort of the unexplained heterogeneity of it. So if you want to define how much is the heterogeneity, which is not unexplained, you can look at the I-square, which is much easier to understand. You can also look at the chi-square as well, which in this case, which is 0.56. So 0.56 is not statistically significant. And the interpretation of p-value from the chi-square for heterogeneity is a little bit different. It is, even if it's less than 0.1, it is considered statistically significant, but there is a difference of opinion in that. The z-test that is below that on the overall effect gives you a p-value of 0.08, which is talking about the statistical significance of the summary estimate itself, which is 0.59. with a confidence interval that includes 1. So if you're looking at the statistical significance overall summary estimate, you can look at this p-value or just look at the confidence interval, as I mentioned earlier. So if the confidence interval includes 1, which is the null value, then that is not statistically significant. Make sense?
Yeah, thank you very much, Dr. Amir. Can you also please comment on the diamond showing the overall effect, how to read this diamond, how the shape changes?
Yeah, absolutely, absolutely. So Nasser, if you go back. So
yeah, show the diamond, this one.
Yeah, right. So so that is, if you kind of look at that, you would see that each individual study, say just above that, the individual studies are represented with the square and then the confidence interval around it. Then the summary estimate is the diamond, which basically tells you where it lies. So the thing that you want to look at is the intervention going in favor or against, right? So in this case, where we are looking at the effect of oropharyngeal stimulation with colostrum, if your summary estimate is less than 1, it means that that particular outcome is decreasing in favor of the intervention, that if you do the intervention, it will decrease. And that diamond indicates the summary estimate. So and in totality, it tells you the magnitude of it, and it also tells you the width of it as well. So if the upper confidence interval is touching the 1, which is the null value, then that shows that it is not statistically significant. If it is completely below 1 or above 1, then you would say that it is statistically significant, and then you make a comment, is it decreasing it or is it increasing it? If that makes sense. Now,
Amir, in this case, sorry, just one sentence from my side. Yeah. In all 3 outcome measures, it is touching the line. That's what I think.
Yeah, it is touching the line, and it's, even if you look at it closely, it's, say, for the second outcome, the B forest plot is 0.78 is the summary estimate. The lower confidence it is 0.60. The upper is 1.03. Now it is just like touching the null value, and I think the bigger part is the relative risk reduction, right? So if we think the relative risk reduction is significant, which it seems like, right? So that's about 22% reduction. If you add 1 or 2 studies, as Safdar mentioned, even if there are a couple of more trials that are published and added to it, this will become statistically significant. But say if the effect size was 0.95 or 0.97, and even if it was statistically significant, it wouldn't matter a whole lot, if that makes sense. It all depends on the clinical significance of it. And I had a questions to all the neonatologists on board about that particular part, because one of the things that I noted was the rate of necrotizing enterocolitis in the control group was kind of high. At least in the United States, we don't see NEC that often. And similarly, the mortality rate was also very high in the control group. So I think there are potentially other variables in the studies that were included from different countries that have other things to contribute to those things. And I just kind of wanted to ask you guys that you can comment after we stop looking at the forest plot. But I do think that there is effect in sort of the desired direction. And if the number of studies, not only the number of studies, but the participants in the individual studies, if the number increases, then this meta-analysis will become statistically significant, which, if you use the grade analysis, they take into account. They don't conclude all of their say certainty evidence based on the statistical significance. There are other things too, like the type of study, the risk of bias, the direction of effect, and the imprecision, which I think at some point in time, Safdar, we can probably arrange sort of a follow-up for the trainees. I would love to talk to people in Pakistan if they want to learn more about meta-analysis. But I think this is a great example and the right topic for it in terms of making a case for use of human milk, and not only the stimulation, oral stimulation with colostrum, but also using the human milk for prevention, for nutrition, for prevention of necrotizing.
Thank you, Amar. I think that would be a great idea to have a talk, like, how to, like, interpret results on meta-analysis, and even, like, how to write a meta-analysis. I think there are a lot of things we can do about it. I think, or would you be willing, because you volunteered, I think we will have to find a window when we can have.
Sure. We are meeting on PAS and we're presenting some of the data, by the way, on human milk banking. We did the reviews for human milk banking for WHO. WHO is going to issue its guidelines for human milk banking, and we contributed 3 papers to that. So I would love to talk. And when you and I meet in 3-4 days, we can definitely arrange that.
Yeah, excited and looking forward.
Thank you very much, Dr. Ahmed, I think, for your excellent explanation as well as your offer to teach us more. We'd love to arrange a session. Inshallah, I will do that. I will get in touch with you.
Dr. Sajjad, just one, I have a hand raised by Dr. Arshad. I would like.
Yeah, Arshad Khushdil wanted to comment.
Right.
Yes, thank you very much.
Sir, thank you very much, Dr. Sajjad sir, Dr. Safdar sir. Sir, I'm a neonatologist working here in Pakistan, sir. And sir, I have been involved with Cochrane in writing systematic reviews and the meta-analysis. And in fact, about 2 months ago, Cochrane Pakistan has been launched as well. And I am being one of the master trainers for the those systematic reviews. And for next 2 days, on Monday and Tuesday, I'll be conducting a 2 days workshop online from 2 p.m. to 5 p.m. here in Pakistan. So if any one of you wants to join that workshop, that will be basically on systematic review and meta-analysis for the beginners. When I went through this article, sir, I want to make, it was a very, very good presentation by Dr. Zeekash and Dr. Nasir. Thank you very much for supervising this journal club. As far as when I went through this article, the having some experience with the medical writing and the publishing it, I think that the process of peer review through which we go here in Pakistan, especially the Pakistan, the journals, the PubMed index journals in Pakistan, the JCPSP, the JPMA and the JPMS, I think they have got a much more stringent criteria and strict criteria as far as the language of the article is concerned. So when I was going through this article, I have published almost 60 plus articles in both national and international journals. And the one thing for which my article has been sent to me back by the editor before sending it even to the reviewer was that it is not written in the English. And this was published in the European Journal of Clinical Nutrition, PubMed Index Journal. And then when the search strategies, so they used colostrum or oropharyngeal administration. So in my workshops, which I conduct here for my students, we do it as the mesh terms and the Boolean operators. So Boolean operators, which we use, so this colostrum or oropharyngeal terms, they are quite different from each other. And that must have affected their search as well. Then if we go down, so, and one of the thing which I would like to say at the, one of the thing was, yes, so they say that the fixed effect model was used. So I would like to comment on this because I am still learning. So I would like to Sarame to comment on this. They are saying that the fixed effect model was used due to low heterogeneity. So what I know and I have learned so far, that when the heterogeneity is more than 75%, so that means that the analysis and the meta-analysis and the studies which are included in that analysis is sort of like it should be reconsidered. It should not be more than 75%. Ideally, the heterogeneity should be less than 30%. Between 30 to 75% is acceptable. But if it is more than 75%, those studies should be again looked into in order to reduce this heterogeneity. And what they are saying here, that the fixed effect model, what I have learned, that the fixed effect model has nothing to do with the low or high heterogeneity. It is basically used when you know that the parameters are used the same. Like, for example, if you know that all the studies which you have considered in your meta-analysis have used the same unit. Like for, if we say that the blood sugar was the outcome, and you know that all the studies which you have included in your meta-analysis have taken it as milligram per deciliter, then you take it as fixed effect model. But if you know that some of the studies have taken it as millimole per liter and some have used it as milligram, I may like to add another example, that if some of the studies have used the length of hospital stay in days and some have used it in hours or other have used in weeks. So if the parameter is not the same, then you use the random effect model. Otherwise, if the parameter is the same, like if it is in hours, all the studies have used the outcome in the same unit, then you use the fixed effect model. So that was another point from my side. If you look here, the heterogeneity is more than 80%. And one question, last question from Sir Amir, I would like you to answer this question. Sir, even if the heterogeneity is 0%, do you think that these studies are so much, what should I say, that they are so much closely related to each other? Some of the studies are done in India. Some of the one study is from Egypt and other studies from China.
Yeah.
And still the heterogeneity is 0%. So
Yeah.
I do not know how this heterogeneity has come 0%. Sir,
Yeah.
that's all from my side. Thank you.
No, thank you, Arshad. This was kind of good and great observations that you have. I think there are a number of things that I could say, but I don't think we have a whole lot of time. I would only talk about the render versus fixed effect models. So the fixed effect model, so you use for any statistical test, you make an assumption before you apply a statistical test. So in a fixed effect model, what you say is that each study that is being conducted has a fixed effect which is same from study to study. So you would say that from one study to the next study to the next study, it's the same effect that's going to be produced by the intervention that you're applying, compared to a random effect model where you assume that there is not only going to be heterogeneity from one study to the next study, which is expected, but there will be additional variation in your effect. And you count that in your meta-analysis. So if you do the meta-analysis with fixed effect model, when there is a significant statistical heterogeneity, it will give you a different results compared to a random effect model, which will include that variance into your summary estimate, which will make it more imprecise. So the confidence intervals would widen with the random effect model in the presence of heterogeneity. And there are more nuances to it. I don't think so we have a whole lot of time, but I would make this comment, though, that the choice of effect, fixed effect or random effect, does not matter based on the outcome. The way the couple of examples to mention, there is a little bit more nuance to that. So for example, if the units of the outcome measurement are different, like say millimole versus milligrams, you can choose a different sort of a summary estimate, which is mean difference versus standardized mean difference. And but the choice of a model for meta-analysis depends on your primary assumptions, and those are based on what you suspect. For example, if you were doing the analysis and you would hypothesize that the effect in Egypt might be different from India, from US, from Europe, and that you would expect that the results will actually be different, you can decide that you're going to use the random effect model without even looking at the I-square value. Okay. And the value that you mentioned of I-square between 25, 50, 75, it is true that, heterogeneity greater than 75% is considered an issue, and in grade you kind of downgrade for it, but that there are nuances to it as well. Sometimes you would expect that there will be more heterogeneity, and if you can explain that with subgroup analysis, then that is counted. For example, if there were some studies that were done in kids less than 32 weeks and then some below 28 weeks, and you do a subgroup analysis and you only see the effect in 28 weeks and not in 32 weeks, then you would say, hey, the heterogeneity is coming because we have pooled these studies from different gestational age groups. So, but I'm very pleased that, you kind of mentioned some of these. There are more nuances to it. I did not know about Cochrane Pakistan, which is happening, which I think is excellent. Who is, by the way, leading the effort in Pakistan to launch Cochrane Pakistan, if I may ask?
Sir, it's nephrologist Jana Sohail Saber, sir. It's Sohail Saber, sir.
And where is he located?
Sir, he's in Rawalpindi Military Hospital, Rawalpindi, sir.
I see. I know. So, yeah, I think he was trained by Dr. Jay Das in Aga Khan.
Exactly,
and
sir.
Dr. Zulfikar Ahmed Bhutta has been, we have done a lot of Cochrane reviews together. And
exactly. In fact, I also have attended a workshop from Dr. Jay Das, sir.
Yeah, he's my buddy. He's really good. And Arshad, you're doing a great job. And only one comment that I would make is, and it's nothing personal about anybody, but we don't need to call each other sir. We're all, the sirs are gone now. The British are gone. So you can call us by name, first name, last name, but it's great that you guys are doing it, and I'm very pleased. And Jay, we got an introduction today. So if you need any help, just let us know. We will be happy to chip in and participate. It's lovely to meet all of you guys.
And you can also share with me the link of workshop. You said it will be virtual, right? The workshop you are conducting?
Yes, sir. It will be virtual, and tomorrow 2 p.m. to 5 p.m. and on Tuesday again 2 p.m. to 5 p.m. sir.
Yeah. If you could share with
I'll
me.
send you the link, sir.
Yeah, thank you so much.
Yeah, I would request Arshad to please put this in the academic neonatology announcements as well, so that the people become aware of your efforts and can join you in this work and learn from you. Thank you, Arshad, and thank you, Dr. Amir.
Thank you.
And I think for the sake of time, I mean, if anyone else has any questions, please go ahead. We may have like a couple of more minutes.
I just want to make this announcement that next month we have a guest speaker, Professor Khaled Haq. He will be delivering his state-of-the-art lecture. And then in June, Dr. Mahjabin will be presenting a journal club. So I have to organize that, and we need help from some of the senior colleagues to mentor her and to give her an idea of a very good article to be presented. Thank you very much. Thank you, Safdar. It was brilliant.
Thank you so much.
You have made us more confident now.
No, Safdar, by the way, if I may suggest, there was a randomized control trial that is published out of the NICU network on human milk and neurodevelopmental outcomes, preterm infants, and it was published in JAMA, and the primary investigator is from University of Iowa that I work very closely. So if we want to continue on neonatal nutrition and use of human milk, I think that will be a good follow-up study to look at, because I think oropharyngeal stimulation is one step, but actually using the human milk for enteral nutrition is very meaningful. And I know there was a lot of controversy around human milk banking in Pakistan. But if we all are well educated about it, I think it's a great intervention and can save a lot of babies from developing necrotizing enterocolitis.